Okay, Dr. Kaplan's back, so we can start now. We just thank you for holding up the proceedings, sir. No. Good afternoon, everybody. I hope that the lunch was up to your standard. It was Habib's regular nourishment before he runs a marathon. So in case you don't know, Habib's going to be running tomorrow morning and will join us at some point mid-morning. Maybe he may or may not finish the race, I don't know. But what is your attempt to break the sub 2-hour marathon? Our next speaker is a wonderful partner to Invitrx, and we are extremely honored to have with us and thankful that Dr. Antonio Carrasco Yalan is here. Dr. Carrasco is a physician scientist from Peru. And I'm going to read a little because he has a very extensive biography. He's a clinical hematologist with degrees, pre and post degrees at the National University of San Marcos in Lima, Peru. He did his postdoctoral fellowship at the University of Texas at MD Anderson Cancer Center in Houston. He heads medical affairs on oncology and hematology at Bayer for several years, from 2003 to 2010 in Bayer, Mexico. And he is now currently practicing back in Lima, Peru, but he does extensive CAR-T work. It's his knowledge and his expertise in CAR-T that brings him to us at this point. And I'm really excited to introduce to you Dr. Antonio Carrasco.
Okay, thank you, Dr. Naidoo. Thank you for the organizers to inviting me. It's challenging after a beautiful, place, after lunch, and after 3 very nice lectures we heard in this previous section. So here we have my disclosure. We will start to talk about a new different field, which is cancer, how the cell therapy in cancer can be used. Absolutely, for a while have been in the field because these cells have the capability of expand, have memory, and have specificity. Of course, we know these cells also have a stimulus and induce the immune system to surveillance the tumor. Also, we know that these cells are like a life drug. And it's the base for the personalized medicine that we already look in the cancer field, okay? So cancer is a very big area, and I'm doing hematology, doing bone marrow transplant for a while, working with cells. But this is not new. We have different areas where the cell has been used, and different ways the cells can be used. We start at the beginning with the NK cells. Also, we start with the activated T cells. The ADCC also is a way that we can use the cells. And we learn to use different monoclonal antibodies to produce these cells, go through the tumor, and also be a specificity and destroy it. We have macrophage that can be also stimulated and targeting the tumor cells. And of course, we have complement-mediated mechanisms to destroy the tumor. What is new here in the field is the CAR-T, which is the area we want to talk this lecture. The CAR-T panorama is like this. If you understand this, and we will be more happy to finish and enjoy the night. At the beginning, you have to understand that you require cells. So the major of the clinical trials and the approval drugs have been taking leukapheresis from the patient. So can you imagine to take cells from a patient after, let's say, 2 years of chemotherapy? That will be challenging because this is an important part of the process to get the cells. It's autologous cells. These cells go to the manufacturing process, to the lab, to Invitrx, of course. We can isolate it, we can activate it, and then we do engineering with these cells. We transduce these genes to the T cells and produce the CAR. I will say in a minute what is mean CAR. And you can have this small molecule expressing in the T cell. And this T cell also then go after this process to expansion to get more cells. This is another important area, how much cells we need. Do we need more than 1 or 2, 10 to the 6 per kilo? Then we go through infusion therapy. So this part of the manufacturing will take over, let's say, a month. This is an important area also. Different techniques are looking to reducing the time. And the patient then go to chemotherapy again. Look at this, chemo here, getting cells, chemo here. So it's a mix of process. It's not just getting the cells. But this chemotherapy that we used to try here as a previous to the infusion is an immunomodulation chemotherapy. We do some lymphodepletion, but we do not induce the patient to a complete neutropenia. As we know, neutropenia can conduce to infection disease. So we got this combination, which is quite standard, cyclophosphamide, fludarabine. Fludarabine was a product that we used a long time doing transplant, the mini transplant, and also fludarabine we use in CLL, which is a type of leukemia. And this combination is go before we reinfuse the cells to the patient. And here start another history to avoid what is toxicity. Toxicity is a quite relevant, important part of this therapy because you have really, really sick people. And you have to be working with the ICU, we're working with different products and taking care of the patient. And then after that, you do monitoring. What happened with the cells? What happened with the tumor? Can we enhance the activity of these cells to control the tumor on the time? That's some important part that is the whole overview of the CAR T cell therapies. So CAR T, let's take a minute to say what is CAR. It's not a new concept. Let's start with this guy, Schnarr, which show us what is really a chimeric antigen receptor. What he got is a TCR, one part of the TCR. They put it another part of the monoclonal antibody, and he produced the CAR. The CAR which you have an ectodomain, an endodomain, and give you some important issues. You can have a specificity here, okay? And also you can have in the endodomain transduce this response and induce the cell to different ways. So this is another cartoon. We'll show you the monoclonal antibody. They give you the specificity and the TCR complex, which is quite complicated to understand. A small part of the TCR complex, you can do this chimeric CAR and then put it in the cell. And this is going to recognize what is the molecule of the tumor. Of course, a different tumor you have, you can select different antigens, and these antigens also can induce this attract to the T cells and sort of activity of the T cell direct to the tumor. Here we have how the CAR function and how the TCR function. This is a normal T cell. The TCR, it recognizes some tumors by the MSC1. And here you have the CAR T. And the CAR T also, you can put different molecules to have an antigen recognition and go and targeting the T cells to the tumor and produce a matter of specificity to the tumor. The TCR is quite different than the CAR. Look at the CAR here on my right side and the TCR. So big difference between us. Okay, the TCR you have the number of units. The TCR is like 10. The CAR is just 1. The number of items, molecules, 10 versus 3. The number of tyrosines on substrate, 20 versus 6. Quite different. The co-receptor we know for the TCR, we have the CD4, CD8, CD28, but for the CAR we don't know, certainly. The typical range of affinity, the TCR have a little bit higher, 10 to 4, 10 to the 6. And CAR, because they have a specificity, you need lower, 10 to the 6, 10 to the 9. the number of surface receptors, the TCR around 50K, the CAR more than 50K, and the minimum number of antigen required for activate a TCR is just one. You can have one antigen and you can activate a T cell, but the CAR you need more than this. Okay, so big difference between what is TCR and between what is CAR. That's also told us the different response that we have during all the preclinical studies that have been done with the CAR T. And here we have a paper, very nice paper. I recommend to take a look on that because it gave us an overview what is happening in different diseases. And of course, they select hematological disease because leukemia, lymphoma, myeloma, some sort of disaster disease because you relapse and you require not only bone marrow transplant, you require chemotherapy, and this card arrived in this field. It gave some overview on that. Also, to recognize that the card specificity, you can select this molecule, and you have some molecules that have been working as CD19, and another mesothelin, the ER2 in different other tumors, to try to do a specificity during the process of the activation of the CAR T cell. That's the CAR T, the most common use is a endodomain or intracytoplasmatic part, the ectodomain, which is the specificity, and we have been working a lot with the CD19. The CD19 is activated, recognize a B cell, a tumor B cell, and produce a transfer and activation of the T cells by the intracytoplasmatic part. The gene transfer of this part of the process has been also quite, I would say, complicated because different protocols and different process. Most of them have been using retroviral vectors, lentiviral vectors. The major concern of this is the integration of the transcript in the genome. The production is easy to scale up. Some others have been using electroporation, MRI. What happened with this, sometimes it's toxic for the cells, but what is good for this is no integration of this no virus-based technique. And you also can use the transposon integration, but the problem is the prolonged culture time. Maybe this can be used in some previous preclinical studies, and this for scale up easily to get cells for patients. So different process to do the transferring. And what is this gene transfer? This is a movie that will show you how the gene go directly integrate to the T cells, and the T cell produce expression of the CAR. So it's a new cell with different other molecules that will recognize the tumor cells. Of course, activate the tumor cell and will produce the death of the tumor cell. We want to see this in a movie. This is a tumor cell, and this is the CAR. You will see that this is really a killer, how the cells in less than 2 hours can produce this in the vitro, and the cells, the Brian cell, the CAR T, this is the tumor cells, can be even explode and destroy. So this is a matter of really interesting way to do therapy, direct therapy, with a fancy way to put CAR T on the tumor and the patient and reduce the activity of this tumor. But here's the problem. The CAR T has been a lot of the engineering process. We have here the tumor, we have the T cells, and of course, this integration has different ways to produce. We can produce different CARs, and here we have the different generation of CARs. This is the first generation. It's not never in the clinical trials. It's really basic, which is the outside part, the inner part. It's just a general way. And here appears the co-stimulatory domains. The co-stimulatory domains gave us a better activity of the CAR T, and can be used the 4-1BB or can be used the CD28. And also, the third generation of CAR can produce and can be produced by 2 different co-stimulatory, the CD28, CD27, the 4-1BB, and also as much co-stimulatory you can have, the more activity you can have, but also more toxicity. So most of the clinical trials are moving on the second generation CAR with just one co-stimulatory, and some other are moving with different, and 2 or maybe more co-stimulatory. Here we have difference between these CAR generations. This is the first generation in red. The second generation you have on the 28 on blue, the 4BBB on red. And there are some difference. For example, the absolute number is extremely high for the 28 and the 4BB, and it's a little bit lower for the regular first generation CAR. And also, if you want to see co-stimulatory molecules, in the molecules you can see interleukin-2, interferon gamma, which is important part of the immunological process, is higher with these co-stimulatories, and also the TNF-alpha, and here you have higher level of TNF-alpha with that second generation of CAR. So this is what we have in the market so far. It's a cartoon published some years ago, but actually it's very well done from Strigen that told us about the NCI CAR by Kite Pharma. It's in the market. We use 28 co-stimulatory. The Novartis CAR-T already approved. They use the 4-1BB, okay? And here we have the Fred Hutchinson card. We just have 2 co-stimulatory. This belongs to Induction Therapeutics. It's not on the market yet. It doesn't have approved. It's on clinical trials. The Kite Pharma is called axicabtagene ciloleucel, quite complicated. We call it Axicel. The Novartis one, we call it Taisa. And the Fred Hutchinson one, they call it Lysocel. So these drugs are quite unique how they produce it. And you go through all the universities and you go through all the labs, they have their own CAR because it's engineered by your molecular engineering, your biologist engineering can produce different CAR because they can put different parts, epitope, co-stimulatories, and also knockout genes. So difference between them, of course we have difference. Look at this. If you took the Kite CAR-T, you will have, after the infusion, a huge and quickly increase of the CAR T cells in the patient. If you use the University of Pennsylvania, the Novartis one, it will be a little bit lower, but it will take a while, more than a year to be disappeared. So CAR-T assume you can prepare different products in your lab. Of course, you can have different response and kinetics, okay? Maybe some people are doing, why don't we do both? We can infuse both, so I can assure to, be strong at the beginning and continue my response. But that will be also so toxic, not just toxic for the patient, also for the economic part. Whatever, it's important also to recognize that we can have here different ways because these CAR-T are not the same products, they have different ways to work and different kinetics. This is the Axicel. Okay, you can see here at the beginning a very high level of CAR-T, and then over a month or 2 months or 3 months, they almost disappear. This is logarithm, this is 1, so they closely and easily disappear. So this is important for the type of maybe your disease. If you are working with a, let's say, myeloma, and it is highly proliferative, you will need something that is really strong at the beginning. If you are working, let's say, for a leukemia with minimal residual disease, you have to be long-lasting maybe, and also you have to select another different product. So this is important for us to understand the kinetics, and also to monitoring. If you want to do monitoring of the response, of course you can do that. At the beginning, here you have to conditioning. You also can do conditioning with another molecules, interleukin-15, interleukin-7. Also, you can put it in the conditioning to prompt a better response. And here we have at the beginning. As soon as you put CAR-T, your level of interleukin-2, mainly interleukin-2 and interleukin-7 is going up. And you can do monitoring on that. You can, check interleukin-2 levels to the patient, and then in this middle phase, there are two parts, the TNF and interferon gamma, which also increase, and this goes directly with the possibility of toxicity, which is a really important part on the CAR T therapy. Okay, if you have more toxicity, if more interferon gamma, more TNF, of course you can have then inflammatory cytokines, which is mainly by interleukin-6, and you can have very bad issue. You have CRS, you have cytokine release syndrome, you can have also neurological symptoms, and you can have a patient to put it into the ICU. And then after that process, because you have to control this part of the process of the activity of these cells, you can do immune effector molecules to see by ground signs and perforins how the response is going, if the patient is going to continue response and keep the tumor control. What is new in the market? In the market appears different publications supporting that. This is the picture of the child with a heavily ALL B cell leukemia after therapy many years ago, published in New England Journal of Medicine, but also published in some important paper magazines of time, show us how it's working. Clinical trials that have been published, and here we have a view, I don't know if you can see at the back, but maybe the major diseases, ALL, leukemia, pediatrics, in adults, CLL, lymphomas, okay, and some patients with myeloma. This is the beginning of a new area, a new drug therapy with these hematological malignancies. And by the last year, we have some approval. These are FDA-approved CAR T therapies. I mean, cell therapies. These are not stem cells. These are T-cell modified cells with CAR approved for patients with ALL, acute lymphoblastic leukemia, and lymphoma. We have many of these patients we send into the pivotal trials to Moffitt Center. They got this therapy, and they're doing fine. Mainly direction by the target CD19 at the beginning. This is the Novartis one. Novartis trials are really fun because they put in names. This is the Eliana and the Juliet trial. And also we have the Kite trials also approved for diffuse large B-cell lymphoma. But of course, in patients after more than 2 lines refractory, most of these patients already got transplant, monoclonal antibodies, second transplant, allogenic transplantation, and then they get into the trial to see response. That's what is so far approved, and many other applications are ongoing, and other companies as well. This is for the B-cell. There's really a way. The B-cell ALL, acute lymphoblastic leukemia, is full of new drugs, new monoclonal antibodies, new targeting therapies, and try to put the CAR T on this field is quite complicated. So a lot of these kids already got monoclonal antibodies, chemotherapy, and then they got the CAR T. The response is really good. Look at this. The overall response for this heavily treated patient is really high, more than any standard of care or even any rescue therapy. And also the toxicity that we saw in this group of patients is another big issue because it's higher and also have to take care of the patient after you infuse the CAR T. And this is another trial for the lymphoma. Look at here, the Juliet, which is the Novartis one, the patient with CR, lymphoma is quite manageable. You can deal with the lymphoma, you can reduce the tumor, and also you can see the response of on B-cell lymphoma. And here you can see the summa, this is from Kite. The pivotal trial also show how the response can be long-lasting and also durable response with less possibility for relapse. Look at the cells infusions for these therapies are different. Look at here, in the Novartis one was 0.1 up to 6 to 10 to the 8 carb per kilo. And here you have the Axicap is 2 to 10 to the 6. Of course, all these therapies, they have a previous chemotherapy, as I said before, with fludarabine, cyclophosphamide to reduce toxicity, and to reduce immunosuppression, and also to go through all this therapy to the patient. This is the CAR T for the non-Hodgkin lymphoma. So far, the responses, the CAR T cell dose is quite different here. And here you have also the patient. Most of them were relapse or refractory relapse patients. Okay, most of them also after transplant, autologous transplantation. Look at here in the Juliet, more close to the 50% after transplant relapse, and they go into the study. And also the manufacturing process is important for this clinical trial. Close to the more than 90% of the patient got the cells done, because it's another issue. How long can wait the patient to get the cells? And the treated was here in the Soma around 90. Here in the Novartis one, 2/3 only get therapy, enroll and get therapy. This is another issue, because sometimes in the waiting list or in the waiting process, the patient can relapse. And here you have your response. Okay, the best response, look at this, for the B-cell non-Hodgkin lymphoma, more than 40, 58, and 59% of response, which is quite relevant for this heavily treated group of patients. After, I will say that maybe this patient not respond more than 10% when you do new therapeutic, new products and new chemotherapies. The median survival, 6 months here, some other not reach. And here have you the durability of the stem cells on the response. Some patients skip a little bit longer than a year. Of course, these are the pivotal trials that told us there is response, is easy and can be managed, the toxicity. But of course, because you have a very treated patient, group of patients, you have to look another, let's say, cohort of patients and trying to move therapy at the first lines to avoid this major toxicity that they have. So far, this is approved. Look at the price of these products. That's the Novartis. And here you have the Kite. But to be honest, for me, this is CAR T-cell therapies is not just this product. All the previous one, all the process, and manage the toxicity and avoid relapsing will double or triple this amount of money. So what is important in any CAR T-cell project and lab is just to understand that your clinician and your patient have to work to try relapsing, because most of these people can relapse. And avoid relapsing is key for the process. Okay, you can do different strategies. I want to talk a little bit to avoid relapsing and also to keep the patient with tumor-free. Now we have for the B-cell and the ALL new strategies. Look at this. People with B-cells, they got chemotherapy. Some patient relapse, of course, they go transplant. As the patient relapse, maybe we can do CAR. So the CAR T moved quickly to the clinic, and we have this algorithm how the patient can be treated. And for ALL as well, we can do chemotherapies, we can do transplant or monoclonal antibodies, and then we can do CAR T cells. Currently, for B cell, it's quite strong, the evidence that you can do chemotherapy. If you relapse, you can do second line, or maybe you can do transplant. If the patient relapses, you can do CAR T cells. So currently, CAR T is in as a third line therapy for most of these people, but more head-to-head comparison are moving to second line, even first line. Maybe there's going to be a lot of information the next year about the second line and the third line for the B-cell, non-Hodgkin lymphoma, and also for the ALL, because they want to move to the first, let's say, second line, even the first line therapy. So can we make it better? Of course, because we have to see candidacy and biomarkers. What will happen? Look at this, the indications, the kinetics of disease progression, the immediate prior therapy, the immunosuppressive therapy, active infection, and no disease-related comorbidities. This is really important for any cancer therapy. To look if your patient have a lot of chemotherapy before, how the patient is doing regarding infections, how the patient keep stable for a while. Sometimes you do chemotherapy, you control the tumor 1 month and the patient relapse. Also, you have to take a look on the cell thickness I was telling you at the beginning, because some patients, they got a lot of chemotherapy and the T cells are already gone, very low and bad quality of T cells, and it's quite complicated to work with these cells in the lab. And of course, that gave us the idea, maybe I need T cells from another source. Of course, we can do that. Also, some biomarkers to tell us about the response. There are some biomarkers regarding the clinical prognostic markers as age, stage, bulky, strenodal, refractory. No ones have impact on efficacy, at least in the SUMA-1 study. The product characteristics, no major difference. The tumor characteristic, no major difference, but here we have another one, the peak of the CAR, which is really interesting, what quickly the CAR increase in the blood, and you can do monitoring by flow, and as much as the higher level, you can have a very nice response, but also toxicity, what is a major problem in this field. Regarding toxicity, this is important for you because when you do cellular therapy, let's say MSC or another product, toxicity can be managed at the beginning and you have to look the patient in the future. But here you have toxicity the next hour. So we do therapies and we start therapies and sometimes the patient at night is in the ICU. Sometimes he's intubated. So you have to work really close with the emergency and the ICU doctors to try to avoid any major complication of the patient. Here you have another way to take a look on some baseline labs, CRP, ferritin, the tumor lysis syndrome labs, which is all these cytokines that we can check, okay? Also, we have to take a look on the patient and look at the fever, how the patient starts quickly with fever. Can you imagine to put cells and start with fever? So you have to work with your nurse to take a look on the patient every 2 hours, taking temperature and looking the patient, and also look the blood pressure, the oxygen levels, and important, the mental status, because here we have these 2 key acute toxicity in this area, which is the CRS, cytokine release syndrome, and the ICANS, which is the immune effector cells-associated neurotoxicity syndrome. There is a lot of information regarding this. CRS is mainly related with interleukin-6 level. That's why we use an interleukin-6 monoclonal antibody to keep it quiet, or at least to stop it. And also we have the ICANS. You know, people really get mad on this. And sometimes the patient have, at the beginning, the CRS. In some hours, they have the ICANS. So this is a problem. We have to take a look on this. There are systems to make diagnostic and also ways also to check and grading and do therapy to control these toxicity problems. Here is a little bit of the CRS, cytokine release syndrome, which is quite broad. Every organ of the body can have some problems regarding neurological, hepatic, hematological problems, constitutional problems, cardiovascular problems, pulmonary, renal. The renal is quite complicated because you can have patients with acute kidney injury. Sometimes patients have to go to the hemodialysis as emergency. Musculoskeletal problem as well. So cytokine release syndrome, you have to take a look and try to avoid it. The best way is to monitoring your cytokines and do therapy, and we show you how we try to manage this with some guidelines for the CRS. Here we have a patient, for example. It's a kid, a young patient got this CAR T at 24 years old. Look at the fever on red. As soon as the fever is high, what is the ferritin that's going up? In green, the LDH. Here you have the CRP, as soon as you do therapy, you can reduce dramatically this and stop the process. You can act with tocilizumab, which is a monoclonal antibody approved for the CRS syndrome, the interleukin-6 monoclonal antibody. They attack and stop it. You can do dexamethasone, norepinephrine, and vasopressin. That's the way also we have to work with the ICU doctors. Norepinephrine and vasopressin have to be monitoring for people who are training on that. Of course, we can do dexamethasone at the beginning, and also, if the patient requires, we can do tocilizumab. And of course, here you have the same option of these drugs, and you can reduce the interferon gamma, at least you can stop it. The interleukin-6, you can reduce, and the TNF-alpha, you can reduce it. So our recommendation would be to monitoring any patient at the beginning of this, let's say the 24 hours after infusion, to do this cytokine monitoring and see how the patient is doing, and try to put these protocols start at the very beginning. If you start late, the problem is going to be bigger, because even you can lose the patient. Here you have a little bit of what happened with the cytokine release syndrome and the icons. Here at least you can understand the endothelium, maybe here's the parasite Dr. Kaplan told us. Okay, here you have the CAR T. The CAR T at the beginning, the activation of this CAR T increased interferon gamma, TNF-alpha. Okay, they produce some sort of pass of these molecules to the brain, maybe act with this, all this part of the neuroglias, oligodendrocyte neurons that produce this very bad problem with the icon, which is the toxicity in the central nervous system. Here you have the frequency of this neurotoxicity in the pivotal trials. Here you have the Axica from Kite. This is from Novartis, the different studies. Look at the grade 3, because this is really matters. The grade 3 CRS, around 13%, 22 here for diffuse large B-cell lymphoma, and for leukemia, 47. We understood that maybe for solid tumors or no leukemia tumors is a little bit lower. For leukemia is higher, and even for myeloma is higher, okay? And the grade 3 neurotoxicity for the Kite around 28, and for the Novartis one, around 12-13% of the neurotoxicity in this patient grade 3. And also the start, the beginning, look at this. This is the CRS, the median onset 2 days. And in one product, in another, the Novartis one, they have 3 days. And the neurological adverse event is a little bit later, that told us that maybe the CRS is improved these neurotoxicity properties. We have guidelines, and this is extremely important for all people on the area, because guidelines told us the grading was different in the pivotal trials. They told us how to manage as well, and recommendation for your hospital to have all on set. If you're doing CAR T-cell therapy, you have to have training people on the ICU, all your medication on the pharma, working with your PharmD, to have availability at the beginning of any symptoms to control this problem as the cytokine release syndrome and the neurotoxicity. Here you have the guidelines. Also, they have an scores. And here we have a small and very nice table that told you at the CRS even in the grade 2, you can start with interleukin-6 blocker. In grade 3 and grade 4 as well. And you have neurotoxicity, you have to check some sort of steroids at the beginning, and then maybe you can do high-dose methylprednisolone. And also you have patients with both adverse events, and you can do a mix of them. Some people have to do you have to do tocilizumab, dexamethasone, also methylprednisolone, and take a look at the patient in the ICU and see how a patient is doing. This is a very nice, you can get it in your app, in your mobile line, which tells you how the grading of the process of the CRS and the icons. You can do the Cartux, which is done by MD Anderson, Dr. Spall, Lisa Spall from the bone marrow transplant department. to show us this very nice process to try to grading and also recommendation, tell you what is the grading of the toxicity and also what will be the recommendation for this patient. Okay, and also you have long-term toxicity. Let's say, okay, you are around 10 days, no major problem with the cytokine release syndrome, no major problem with the neurotoxicity, but you can have B-cell aplasia, you can have cytopenias, you can have infections, even you have to look for second malignancies. This is quite the same for any patient that go to transplant, bone marrow transplant. You have to look in the allogenic setting, these sort of major problems that appears over the 3 months on the road and check what the patient is doing. What is new in the literature? This is the map of the CAR-T activity, clinical trials.gov. I show you here how China is really active in the area. This is protocols open and running. Here we have US, Europe. It's not much as MSC as you can see, but we have a lot of activity on the CAR-T. And also in the same, we have 9 clinical trials working on NK T cells. Sorry, NK CAR cells, whereas the same concept. We know with a T cell also working with another cell, which is the NK cell. Here we have another new protocols on the field with these new companies in different area of the lymphoma and leukemia, and moving the concept second line, even head-to-head first line. Here you have this look at this name of the studies: Belinda, Oberon, the Suma. You have here Cassiopeia and Amelia, which is different studies trying to move the concept in the very beginning process. Here we have another protocols, and there is really important for the myeloma field. You know, multiple myeloma is a disaster disease. You can be as a chronic patient, but also the bone are broken. You have also problem in the renal disease, the calcium activity. So patients with myeloma require sometimes different therapy because every new drug they can use, the patient can relapse. And here you have another concept for the CAR-T doing the BCMA, which is the target. There are different clinical trials, and the bigger ones comes from China with a response rate of 74%. This is amazing because this group of patients is really heavily treated patient, more than 5-line therapies after autologous transplant, allogenic transplant, and even they can respond and recover their bone marrow and also continue fighting with the disease. So this is really interesting what is happening in myeloma, and many new studies are going on myeloma. Look at these new numbers of studies. You have the CARTITUDE, the EVOLVE one, and another that are looking for the myeloma field. And here you have another studies on the CLL field that is quite advanced. Most of them are in phase 1, phase 2 process. What is new on the scope, just to finish, we are working also for another disease, which is Hodgkin disease. We are targeting the CD30 molecule. Also, they are working CAR-T against T-cell lymphoma. That will be challenging because to do a T-cells, engineer a T-cells, to put it into the patient, to control a T-cell lymphoma quite be complicated because it can produce a fratricide therapy and risk, of course, of T-cell aplasia and infections. Also, they are working people trying to block the TNF-alpha interferon gamma at the beginning to avoid toxicity and put the interleukin-6 blocker if they require. This is good to avoid toxicity, but nobody knows if you can avoid response. So you can control toxicity, but you also can lose what is important in the cell therapy. Other people are doing allogenic bone marrow transplantation after CAR-T. I will show you in a minute, a lot of patients with CAR-T therapy can relapse. So they are doing as a bridge therapy and then go over a allogenic BMT. The problem with the allogenic BMT is you have a donor. You have a donor, easily you go through allogenic BMT, and sometimes you have to look in the registry, in the worldwide bank of the donors, of bone marrow donors, and sometimes you don't have the lucky to get a good donor. And it takes a while, it takes like 6 months sometimes. People from MD Anderson, this is a really new concept, are doing cord blood, CAR-NK cells with a no toxicity, and also it's not required the HLA match. This is a really nice concept. People from the Dr. Spal lab, we were discussing in Houston last month, responses are really interesting, very refractory patient, also getting cells with no major toxicity. Another people are doing therapies previous to get T cells. Remember, T cells have to be in good shape. T cell thickness. If you have a very bad T cells, forget it. You have to get another T cell source. But you can improve your T cells by doing some therapy previously with azacitidine, which is a hypomethylating agent we use for MDS, myelodysplasia. Also, another people are doing CAR T cell from healthy donor, of course. And people also are working with targeting with 2 different monoclonal antibodies or doing dual transduced CAR T, which is quite different, and we don't have major information regarding toxicity on this. So this is Selectis. They are doing, for example, healthy donor. It's allogenic CAR T. We will see the responses. More challenges on the road. Remember, approximately 20% of the patients do not respond, and another 40% will relapse. So it's an interesting field. It's a interesting weapon that we can use, but we have to monitor it because patients can relapse, even do not respond. There is some ways to do this. The patient have some antigen escape, so the CD19 change, and your card will not recognize this CD19. Also, you can have impaired T cell, back T cells, and you have to work on this, or maybe get T cell from another source. There is another important one, which is the PD-1. Look at this. Checkpoint inhibitors, PD-1, have been involved in many tumors, and we recognize that people who relapse will have major expression of PD-1. So people are doing now some sort of maintenance therapy to keep the PD-1 low and avoid relapsing. And here you have different examples, different studies, Alexander platform and the SUMA-6, that combine these monoclonal antibodies after CAR T. So CAR T price will be part of the product, manufacturing, but if you put all the process, previous, during, and after, to monitoring your patient can be higher to understand what is important in this process. Also, people are doing now knockout genes encoding PD-1 to try to avoid relapsing or lose your CAR T cells activities in the future. Here you have important, we discussed this with Invitrx sometimes regarding what is the induction therapy. The conditional therapy must be cyclophosphamide fludarabine. This is quite standard, very easy to do. Even you have oral medication to reduce a little bit the TB NK cell activity and put your cells with some really good environment to avoid major toxicity. Okay, this is well known. Here you have what happened with the patient who relapsed, the PD-L1 monoclonal expression. This is important because you can also monitoring if you have a patient that may be gonna relapse after CAR T, you can do this really easy immunohistochemistry biopsy, and can also add before any major clinical relapse. And in the case of of myeloma, look at this myeloma patient that we have in Lima. This is a lady, 10 years with myeloma. She got almost 10 different monoclonal antibodies and also chemotherapies to keep the disease quiet. but he also relapsed. So she went to this clinical trial, and also he got BCMA CAR T, what also conduced to a major control of the disease. Currently, if the patient relapse, we can have also CD19 negative self, or also we can have CD19 positive self. In the case of the patient have a CD19 negative, you can do different cards. There are some experience of patients who lose CD19 expression. You can do another different card to try to keep the disease quiet. And also, in the case you have CD19, you have also change, and you can induce some different response if you attack the apheresis product, or the CAR T-cell product, or the pre-infusion conditioning therapy, or the post-infusion conditioning therapy. Here you have, look at this, the PD-1 monoclonal antibodies, and we have a new idea also to increase response using ibrutinib. Ibrutinib is an oral medication used for CLL, for mantle cell lymphoma, and also for Waldenström disease. It's really oral, is good for patients, and also can induce a better response, to have a better T cells, to avoid major toxicity, and also to keep the cells, the CAR T in good shape to try to, control the disease in the future. Finally, the complex organization of any CAR T cell therapy programs is not just the lab. You have to work a lot with people at the beginning to try to look the good candidate patients and the realistic, outcomes that you're gonna have with this patient. Also to take a look of the infusions, on the process, of the early care, the late care, and all times regulation of this system. The FAT also gave some guidelines, what is really required in different protocols, hospital programs to give the CAR T. The CAR T also can give you a view how well is your hospital, your site organized. And of course, you have to get ready for your ride. You can select your car, what is your preferred, maybe have it here, your car. You can select your highway, different disease. You can do leukemia, you can do pancreatic disease, you can do glioblastoma, you can do prostate. Whatever you can do, also you have to continue the process and keep this process on the disease, because it's quite different. Also, you have to check all the regulatory and what is going on in the field. That is something really important, because each day we have news about toxicity, or new ways to avoid toxicity, or new ways to try to look safety for the patient. And also enjoy your ride, because it takes a while, to prepare all this process and keep your patient safe, and look at the patient safety at the beginning and the end, and the process and the end. Finally, I want to show you a little bit of what is Lima. This is in my medical school, San Fernando in Lima, Peru. Belongs to San Marcos, the oldest university in America, the oldest. This is my hospital here in Lima. It's 1.5 thousand beds. A lot of big hospital. Another hospital that we were working, this guy here is Dr. Champlin. We were 20 years ago in MD Anderson doing transplant, at that time allogenic transplantation, now moving for new therapies as the CAR T. Here we have my institution that I'm working in the clinic, Clínica Delgado. I spent a while working in Bayer in Mexico, and also with the people from Germany. And here you have MD Anderson. That photo was taken many, many years ago. Currently, it's really big, disappeared. They built everything, and they have a big facility, and also more than 100 patients treated per year with CAR T, with a lot of experience on growing on the field. I will send to you, and we'll be happy to respond to your question and to hear about your comment. Thank you.
Thank you so much, Antonio. I promised you that we'll open up for questions to all the panel members shortly for the interest of forwarding the program time-wise, and I know that most of you seem to be blurry-eyed at present. Do you guys remember the movie Hangover 2? So I'm just going to shut this down because I have a ton of slides to show, and I promised you that I was going to cut my talk down to 5 minutes, and I'm going to do so. So if you remember the ending scene from Hangover 2, when Mike Tyson is singing up on the stage there, and Zach Galifianakis says, really, we don't own him, we just have him we rented him for the hour. So I was reminded of the fact that we have world famous speakers here, and we just rented them for the hour. So I'd rather give the podium to these speakers to answer your questions and to really inform us a lot more. Most of you here have heard me speak too many times, but I'm going to take this 5 minutes to let you know that Habib and I have listened to you over the last year. You've had inquiries, questions, and a lot of questions, a lot of demands. One of the most common demands are, what are your protocols? Another one is, do you have clinical trials? Do you have literature to share with us? And to those questions, I used to look to Ken and say, are we allowed to? Are we allowed to, Ken? Regulatory-wise, we were unsure. We were unsure whether we could advise you on clinical use of our products. Without regulatory direction, we were uncertain. Were we transgressing the law? So personally, those of you that I offended by not giving you adequate information, I apologize, but now you understand why. In light of the fact that we have a pre-IND application, I think that we are on a good pathway right now to make suggestions. Clinicians in the room, a lot of you, and how many clinicians? A show of hands, okay? So a lot. So what are you waiting for? You're waiting for direction. What are the indications? How can we use this? Where are we going to use it? Basic scientists in the room, you guys are giving us a lot to think about. You have now just changed the paradigm a lot. I was going to show you an hour worth of literature slides here. I did a deep dive into the literature, and I have a lot that's available to you. Sean will make that available to you. But I'm going to summarize all those slides, a couple hundred slides, 133 slides on literature that I have. You know what? Very simple. They all say the same thing. There's great promise to cellular therapy. The stem cells, the Kaplan cells, and the exosomes are immunomodulatory. They show some promise in therapeutic intervention, but well-designed, randomized, prospective clinical trials are necessary. That's it. That's a summary of an hour's worth of talk. And guess what? It behooves us now in the industry to actually provide those clinical trials. So to date, we've done a lot of clinical studies. I've personally been involved in a number of clinical studies. Of course, we can't call them clinical trials. They don't have an IND with the FDA, and they don't have an IRB. I had an interesting discussion. Dr. Kaplan called me last week, and I was in the middle of writing the clinical experience for the pre-IND, and sort of he conveniently disturbed me in the middle of it, thankfully. And then his ending remarks were, my advice to you is keep persevering, which is what we are doing. I think we've changed the status, we've changed the arena sufficiently that we do not have, although we should be cautious, but we have some pathways right now towards FDA regulation. I have been involved with a clinical study at Harvard University, and I had the privilege of being offered grand rounds at Harvard at the Brigham and Women's earlier this year. Even though we presented our data on 5 years worth of treating patients with chronic Lyme's disease with cellular therapy, amongst the protocol, I'm a big advocate of combination therapy. I do not believe that you should use cellular therapy in isolation and avoid the rest of the tools that we have as clinicians. I believe that our therapeutic interventions are adjuvant to everything else that we have. So we used, at Harvard, we used stem cells as an adjuvant to the rest of the therapeutic intervention for patients with chronic Lyme's disease. Our results are good. But our biggest stalling point right now is that Harvard wouldn't accept us for an IRB. I discussed this with Dr. Kaplan earlier, and he said, you know what, persevere. In 2 or 3 years, when they do give you that IRB, that is going to be worth a lot. So yes, I think that we should persevere with our clinical studies, and we should persevere on the clinical pathways. There's going to be stalling points. There's going to be issues. One of the biggest issues Dr. Kaplan brought up again earlier was informed consent. Informed consent is big. If you do not consent your patients adequately, well, who's liable? And whose fault is it? We should adhere to the basic principles of medicine and stick with it. And use stem cells, use the Kaplan cells as an adjuvant to our current understanding of disease treatment. We have a vast experience, and for this pre-IND trial, Ken and I dug into the last year of patients that I did. It seems in keeping with what our basic scientists are saying. Our clinical experience seems to be in lockstep. We have an ability to reduce inflammation. In fact, I see that very significantly. I treated 33 patients in the last 6 months who had shoulder surgery with me and received stem cells, and compare them with another 33 patients who did not receive stem cells at time of surgery. Results head to head are amazing. This is anecdotal. Patients who received stem cells used 0 narcotics post-op. Patients who received stem cells had a range of motion within 3 days and an average of 3 times faster acceptance of physical therapy and return to function than patients who did not. So we see this. My Harvard experience shows that we are actually treating infections more effectively with Kaplan cell therapy. So we have all this as anecdotal evidence. And as usual, as I did in past years, I implore you clinicians in the house, please put this down as evidence on paper. Please do effective clinical trials. Take the good clinical practice module from us.gov. Understand how to run a clinical trial first. Understand how to educate yourself, your staff, and your patients on the clinical trial. And then have very effective ways of data collection and metrics that we could use. We are clinicians. Let's do it. Let's assist our scientist colleagues in how we can approach the industry. Well, that was my soapbox. In closing, I thank you all for your presence today. I especially want to recognize a lot of you here who are outstanding physicians, outstanding partners to Invitrx, our medical advisory board who did a stellar job yesterday as well. Thank you so much. The contributors to all our work worldwide. We thank you. I thank our CEO, Habib Tofi, for giving us an amazing platform to do this work that we love. I am now going to throw the podium open to questions. I will promise you that the next 40 minutes, we're going to keep the mics open that you can ask our panel all the questions that you need. Ladies and gentlemen, with my appreciation, thank you very much. Kaplan, you want to, yes, sir. Okay, we have an audience mic, which I'm going to be managing, and we have a speaker mic. So the floor is now open to questions. Sure, you've been eager for a while.
This is for Dr. Kaplan. I do a lot with inflammation because my specialty is in trauma rehab. And, you know, we talked about the Kaplan cells, as we're calling them, relating to the inflammatory response and blocking the opioid receptors. I heard this before, that there's a big difference in the acute inflammatory response versus a chronic inflammatory response, especially in terms of like the macrophages. Do you see like a difference in terms of an acute injury compared to a chronic long-term condition in reference to any kind of mesenchymal treatments?
So I don't think there's enough data to make a definitive statement. What's clear is that the acute inflammatory response is in essence a cytokine storm in a similar way that we see it with CAR T and with other cell-based therapies. It's a response of the body to a particular treatment or a particular malady. I think that when you give MSCs and how many you provide and how you provide them will determine the outcome. If you do shoulder surgery, rotator cuff, you have a confined capsule that you can squirt cells into. If you have a heart attack, putting them into your shoulder ain't going to help you. So, for example, the most effective treatment for delivering cells to the heart is actually a corkscrew catheter that screws into the muscle, and when you screw it out, there's a hole, and that's when you squirt the cells in. So there'll certainly be some cells that bind to the injury site of the corkscrew, but also one of the problems in answering the question that you asked is where's the inflammatory response managed? So what's not well mapped in the human body is the lymph system. So to the best of my knowledge, there's no map of the lymph system which services the heart. So if you have an inflammatory response that affects heart tissue, it's in the lymph. All of the T cell antigen processing, all of the expansion of T cells is done in lymph tissue. So the corkscrew catheter may be good for ischemic muscle, but I don't know how it services the inflammatory response that's associated with cardiac tissue. So again, we're flying blind in various tissues of the body because we don't know who's responding and where the responsive sites are. So I can't answer acute versus chronic. I think chronic is also a question, is a newly diagnosed rheumatoid arthritis patient the same as a rheumatoid arthritis patient that's been treated with every drug in the book? So the FDA, for example, will only give us non-responsive patients. They're called refractory. Thank you, no. I don't want to have to deal with somebody who's already failed every drug on the shelf. I'd rather have a new patient, newly diagnosed, who's seen no drugs, because then I believe the cell-based therapy has a better chance. So again, the age, history, and patient phenotype and what the FDA will allow are all of the questions that's embodied in the question you asked, for which there's very little data.
In fact, JAMA published a paper by the CT surgeons from Mount Sinai in March this year, in which they treated the patient over a 6-year period, patients who were on cardiac pumps and showed no improvement with cellular therapy. Yet Jay Trevize and his group out of Baylor over time showed that the timing post-myocardial injury is very important. And later studies, including Dr. Sawa in Japan now, is showing that if you treat injured myocardium with cellular therapy within 15 hours after injury and with high doses of Kaplan cells, that it barely keeps up with the level of damage of the myocardial cells. So
there's a excellent series of papers by Mark Penn,
yes.
In which he shows that acute myocardial infarcts are diagnosed by how much SDF1 is released from the injured tissue, and that indeed the MSCs go to the peak of SDF1. So in humans, if you give MSCs within the first 48 hours of acute myocardial infarct, you'll hit the peak of SDF1 secretion. If you give them at 1 week, there's no SDF1. True. So the Mark Penn solution is to give a plasmid for SDF1 to the patient who has chronic heart failure, get the SDF1 to be secreted by cardiac cells, and then give them MSCs, or hope that their intrinsic MSCs get to that site. So again, treatment plans and what's causing the docking of particular cells in particular sites, what molecules are involved, are hugely important. Again, certainly in all the animal models that I know of, for acute myocardial infarct, it's the secretion of SDF1 which is the key variable to the progression of that malady and to the efficacy of the MSCs that are added. So again, where a particular patient is in their response profile to acute myocardial infarct should be ascertained. We do creatine kinase levels to know the severity of the heart attack, but we don't assay by ELISA in the serum for SDF1. So again, treatment protocols have to understand and use the information base that we now have, which I'm sure will become refined as we continue to use these cell-based therapies.
So the usual paradigm as a clinician, we treat our patients with early intervention. The earlier you intervene in any disease process, obviously the better with whatever we use, whatever tools we choose to use. Cellular therapy is the same way. Your analogy of the moment you have chest pain is going down the street to 5 minutes of getting Habib cells and IV infusing them is actually very appropriate. But what about preemptive? What about saying, I'm getting old, I hit that 50 corridor right now. What about getting IV stem cells as a preventative?
Well, again, you have to be very clever in choosing your parents in order to understand your genetic response profile. So if you choose your parents inappropriately, you won't respond well. So genetics plays a huge role in response profiles. And so, there are patients who have acute myocardial infarcts who recover fabulously. There are patients who don't. There are patients who get knee replacements who, at the end of the year, are still complaining of chronic pain. But that pain is different than the pain that they had when they started. It has to do with the operative procedure and scar tissue. So again, depends on the cause, depends on the effect, depends on your response profile. I think we don't know all the variables, and we don't know the things to assay at the moment, but we're working on it.
This is for Dr. Kaplan. Do you think that measuring a patient's circulating MSCs would be a possible way to identify who would best respond to MSC treatments, especially IV treatments?
Yeah, again, if you ask all the MSC jocks in the audience, they'll tell you MSCs don't circulate. There's 20 or 30 papers that are published that say MSCs do circulate under certain conditions. We don't know what those conditions are. And so, for example, we don't know, people who have chronic lung problems, for example. We don't know if their MSCs are circulating because of these horrible fibrosis that they have in their lungs or other problems. So the answer is circulating MSCs, A, are hard to analyze, and B, we don't know what that means. I can tell you that if you take a rat and you grow it under very low oxygen pressures, within a month the MSCs are circulating. So is that because you've mobilized them, or is it because the animals have a bunch of broken blood vessels because of low oxygen tension? So I don't know the answer to that. But I can tell you there's circulating MSCs under those conditions. So again, low oxygen, bariatric treatments, a variety of drugs, we don't know how that affects MSCs in the circulation, and we don't know whether the MSCs that are circulating are going to be the same as Habib's MSCs that we put into the bloodstream, and how they're affected, how they affect the recipient. So again, those are all black boxes.
Can I add something regarding the response? So it's very difficult to determine which one gonna be responder, which one not. So ideally, and there's two variables. Let's say you want to do some in vitro test. The recipient, even different, they have different response to different donors. So let's say donor A, if you give it to donor B not going to respond. But donor A might be good for donor B, and vice versa. So there's two types of variability. The only way to do it is to test. So, and ideally you want to have a bank of cells from 10 different donors, and your recipient, let's say you get their PBMC, you do the in vitro potency assay, determine which donor respond to which cells. So that's the only way. And this is, as Dr. Kaplan mentioned, this is only in vitro. This, even if you get the best responder, in vitro, good, increase the possibility that you get a better response in the clinical trial, but that doesn't guarantee that you're gonna succeed. So it's just, you can increase the chance of getting it to work by doing extensive in vitro test before doing the clinical trial, but doesn't guarantee. Not sure if I answered your question.
Good afternoon. Thanks for being here. My question is about antibiotics. Most of my doctors are prescribing heavy antibiotics after surgery. Doesn't that defeat the purpose of having cell therapy and antibiotic thereafter? It's going to kill the cells anyway.
Yeah, so I use this kidney transplant paper that's in JAMA as an example of what I would call an optimized presentation protocol. In an operative procedure, I would like MSCs as soon as the operation is finished, because I have lots of damaged tissue, and I'd like those MSCs which are presented in the blood system to get to sites of injury. That said, I probably want another shot of MSCs a couple of weeks later, because now I'm in the recovery phase, in the regenerative phase, and I know that MSCs are very important during that phase. So I'm a two-shot man. Again, the FDA doesn't like 2 shots of anything. For rheumatoid newly diagnosed rheumatoid arthritis patients, we have a phase 1 clinical trial going where we specifically have stepped up from a few patients at 1 shot to a few patients of 2 shots separated by 1 week, and then a few patients at 2 shots, 1 immediately and then 1 2 weeks later. And we have outcome assays that we think will tell us whether they're responding, not that they're responding completely, but whether they're responding. And the cells that we're interested in vivo are T cells, because those are the cells that are involved in rheumatoid arthritis, and those are the ones that are very over-aggressive in how they're dealing with the patient. So we think we need to pre-treat the MSCs that we're going to use in the allo MSCs that we're going to use in the trial to see how those MSCs will respond and influence T cells. And so we're picking donors who have what we think is an optimal influence on T cells. But in the end, it's the T cells of the individual patients that we care about. So in this scientific study, we're comparing T cells from rheumatoid arthritis patients to T cells from normal patients. And so to see if their response profile is different, and we see differences. So again, how you predict a response, we're still in the dark. How we imagine the cells are going to respond, we have hypotheses and we're trying to test those.
I guess just an open question to the whole panel as well as you, Dr. Rajen. To kind of follow up on that question, there's a lot said about the host of injecting it. You don't want to take anti-inflammatories for a certain period before or after. You don't want to inject into cortisone. When can I take antibiotics? What kind of research is out there that kind of gives guidelines? And a lot of people are talking, well, it's not any good if you don't alkalize the patient, get the environment host ready for it. I think that's something that we don't really have clear direction in the field in.
I don't think there's any data that I know of that can tell you what's the optimal pre-treatment and what's the optimal presentation of cells. I think we don't know.
There's been a lot of mythology out there, and that we've heard over the last 5-6 years. But I can tell you from my own clinical experience that I've injected the stem cells that we produce into patients under different circumstances and in combination with other medications, and it does not seem to have a clinically different effect. So in other words, if I've injected cortisone into a knee as well as mesenchymal stem cells, the clinical effect is the same. And it doesn't seem to influence the efficacy of the stem cells in any way. At time of surgery, I will inject alongside a cocktail of anesthetics, short and long-acting anesthetics, as well as NSAIDs, with great results. So there's some literature out there that the stem cells are incredibly hardy, that they are not affected by an alkaline or an acidic environment as long as it's not to the extreme. Variations from neutral seem to be not significant.
Yeah. In the case of cancer, we'll say cellular therapy for leukemias, we do use these sort of lymphodepletion therapies. We prefer cyclophosphamide and fludarabine. We do not use any corticosteroids. This is quite nice and well demonstrated to prepare the landscape for any cells, autologous, even allogenic cells you're going to use. So we do. Otherwise, your T cells or your dendritic cells, even your neutrophils, will kill the cell that you're putting in the patient. So in cancer, most of the protocols and our experience is to use this conditioning therapy before any infusion.
I just want to add a a little bit regarding the timing of injection of the cells, stem cells. That depends on the cell. MSC likes these inflammatory signal that they can help them to go to the inflammation site and release all those anti-inflammatory. That is not the case for, let's say, neural stem cell. So there were two groups that you see, everyone, this is the example. Both using the same cell for neural stem cell for spinal cord injury. One saw the efficacy all the time, one failed all the time. So they sat together to see what's going on because they used the same animal model, the same procedure, the same cell. Then they realized that the time of injection, the group that doesn't work was right after the putting the injury to the spinal cord. That create like a heavy inflammatory environment, which is so harsh for neural stem cell to survive. They don't behave like an MSC. So they used to be like killed, initially exposed to all those inflammatories, high levels of inflammatory cytokines. Versus the other group, waited 1 week, then they injected neural stem cell. That's why they did the efficacy. They saw the efficacy. So we cannot generalize those timing for all the cells. Each cell is different, based on the whatever mechanism they use to do their job.
So we've treated quite a few patients and with mixed results, but the one thing that's been consistent is that some patients have come back and said that they've experienced fatigue right after a IV. So I would like to know your opinion on how I could address that and start preparing patients for that. Never heard that. Just they come back and said that they felt tired 48 to 72 hours after an IV, and after that they balanced out and did great.
No data. My gut reaction is the 72 hours their adrenaline wasn't maintained. So, when you get these shots, patients have very high adrenaline levels because their expectations are very high. And I don't have any scientific or data-driven explanation, but my gut reaction is they walked in supercharged and they couldn't maintain that level of adrenaline. But that's just off the top of my head.
Ken, you can try.
Just to, do your patient have some sort of flu-like syndrome? It's just this, tiredness or something?
We haven't experienced flu-like symptoms. It's just been fatigue, and it's
Fatigue.
not something that
Some
debilitated
pain?
them. Not for the IV. This was more for systemic reasons, maybe arthritis or something like that.
Okay.
We're targeting, but they did fine. They actually, after the 72 hours, a lot of them did great. It was just in that window, and I like to talk to the patients and prepare them for whatever they may experience, so it's not a surprise. So I've started telling them that you may experience fatigue up to 72 hours, so it's not a surprise. And no red flag.
I can tell you standard office procedures in many interventionist therapies is they take somebody's blood pressure when they walk in the office, and then they take somebody's blood pressure when they walk out of the office, and somehow when they walk out it's less. And so that's where I got my adrenaline hypothesis. But again, there's no scientific basis that I'm aware of for fatigue.
I just wanted to answer, or at least weigh in on the statement you made where one dose and then you can't do a second dose for a while. That may be the wisdom of your clinical reviewer. I was involved in an IND for refractory solid tumors, stem cell type products or cell products, and I proposed that the regimen should be 5 infusions over a certain amount of time because you're dealing with refractory solid tumors. They allowed us to, in the initial cohort, 3 of a low dose, to do the 5 regimens. Now, either they were not astute or they understood that you have to start with the right dosing frequency over time. And so the first cohort got a low dose, put 5 infusions.
Yeah, but I with all due respect, life and death therapies for cancers, and quality of life, as the FDA calls it, quality of life procedures like knees that hurt are given different values.
Absolutely. It was the refractory solid tumor which allowed us to do that.
No, for sure. And so, but rheumatoid arthritis, for example, you can expect that Mesoblast has a phase 1 or phase 2 trial on rheumatoid arthritis, and the only thing the FDA would allow them to do is refractory patients. When we went for our IND, I said, no, thank you. And there was a spirited discussion between us and the FDA, and finally they allowed us to deal with newly diagnosed patients. So again, I don't want refractory patients, and actually 2 shots also required a spirited discussion with the FDA, and they gave us that only after the safety committee would look at the first 5 patients that got 1 shot to make sure they were still alive. But it was.
They expect a 1-month safety evaluation of all the parameters before you go on to cohort 2, for sure. I know that.
Thank you, Ken. Dr. Shah?
Thank you very much. It was a wonderful discussion. I like to ask very quick question that is there any benefit or combining the PRP with the stem cell or the Kaplan cell, does it make any sense or does it help better way?
Yeah, so I'm strongly averse to mixing apples and oranges. PRP in your joints has a very specific effect. It goes into the synovial lining and activates MSCs. So the issue is, why provide MSCs? And or vice versa. Don't mix therapies. If you're going to give a particular therapy, give the therapy. I would challenge you to have an assay in your office for the potency of the PRP that you use. Because I don't care what machine you use, you do the same 50 cc stick on the same patient, you'll get 2 different PRPs. I don't care what the company tells you. So the issue is potency. And there's ways of trying to, for example, there's simple ELISAs for PDGFBB that you could use for potency, even in a doctor's office. And as a matter of fact, I have a product which is like a pregnancy test. It's a piece of filter paper where you dip it in PRP, and if it turns blue, you can use it. If it doesn't turn blue, you can't use it. It's just an ELISA on a piece of filter paper. I can't get any of the companies to support the clinical trial for that product because they don't want to know the answer.
Yes, exactly.
So it's a very important point, and what every physician in the room knows is, and I'll just take a minute to do this soliloquy, which is everybody knows there are non-responders. So in all the drugs that are currently sold, whether it's prescription or over-the-counter, there's at least a 30% non-responder group. So if you have a headache and you take Tylenol and it doesn't work for you, you're a non-responder. Tylenol works for headaches. That's how it was originally approved. So the issue is, in cell-based therapy, what's our expectation for the percentage of non-responders? All the public information that I know from Mesoblast, Osiris, all these other companies, is that at least 50% of the patients are non-responders. That's a tuning issue. So if you consent the patient and you say, the the recorded information that we have on this particular product is that it's a 50-50 chance. That's proper consenting. And that's an important aspect of what's not being done. So you have to know what the outcome data is. And if you have no outcome data, you have to present your best guess. But your best guess should always be lowballed, because otherwise you set up real placebo expectations. And so I want to talk about, because Dr. Berger here and I are going to have fights about this, is the FDA and the academic PhD snobs who think they can tell you how to practice medicine in certain groups. They say you need a double-blind, placebo-controlled trial to tell anything. That's a big pharma logic. That has nothing to do with cell-based therapy. I've just published a paper which is called a non-responder. So I suggest if the 50% non-responders for cell-based therapy, that we eliminate the placebo control completely. Eliminate the placebo control completely. So if you have 50% of the patients are non-responders, that's called a floor. If you can't show a statistical significance to the responder group, then you don't have a drug or you don't have a procedure that works. And so that eliminates all of the complications. You can have statistically relevant clinical trials with 100 patients. If half of them are non-responders, that's the floor. If you can't show a big enough response above that, you don't have a therapeutic product. So again, in this case, every patient gets the same treatment. There's no blinding that needs to be done except in the physician who's actually scoring the patient. There's no blinding, because when we started the first clinical trials with bags of cells, every doc who had a bag of cells knew what a bag of cells looked like versus a bag of saline. So we had to tape the damn bags so that the doc wouldn't look at them. So again, placebo controls and everybody's mentality about what's an efficacious drug and what's not an efficacious drug is structured by the big pharma. Big pharma can do 5,000 patient trials. We can't. We don't have the resources to do that. But we could do a 100 patient trial and do non-placebo. We know if you inject anything into the knee, we know what the placebo effect is. If you inject anything into the shoulder, we have data, we know what the placebo effect is. If you inject anything into somebody's arm, we know what the placebo. We've been doing this for 30 years. So again, this is a new industry. We have to together lobby with the regulatory agency, and if they say no, of course we have to do what they say, but we can affect the way clinical trials and statistically significant effects can be identified, and that'll help everybody in the way they consent the patient and the way they have their own expectation for a particular clinical moiety.
What you have suggested is de facto historic controls, and you know the FDA is not going to accept that. That's old school. I'm not saying that you're wrong. I'm just saying you're talking about historical controls, and you have to have.
You have to remember that all the guys at the FDA are young, so they don't have any memory of old school.
Question right here.
All right. Great presentations. Wonderful way to build neurons here on in Newport Beach on a Saturday. So we've talked about Kaplan cells. We've talked about exosomes. Clinically, I've had mixed results, but mostly positive with Wharton's jelly Kaplan cells. But it's taken 4, 5, 6 months to see that response. For exosomes, I've asked them, a whole bunch of us here, how long does it take to work? I've had immediately, 2 weeks, 1 month, 3 months. what are your responses for how exosomes work? Can we mix them? And what do we do? Is it efficacious to mix them? And how would you approach that?
So remixing, I'll leave it to Dr. Kaplan, but efficacy for exosome, you first have to ask them, what is the source? Let's say they all say Wharton jelly. Even that, you have to ask them how many how many samples did they try? Is it just one time? Because there's a lot of donor-to-donor variation. This is what we see at City of Hope. We do see umbilical cord exosome. Some of them are so immunosuppressive. With low dose, they can shut down all the CD8 positive, CD25 positive cells. Some of them, they do nothing. Even they increase the population. So they are immunostimulatory, even immunosuppressive. So first, there's a lot of, one layer of complexity is donor-to-donor variation. Second layer is how do they do their isolation? I said in one of the slides, process is the product. The way they isolate, the way they culture the cells, the way they resuspend, how long they do their collection, all those processes which leads to that vial of exosome matters every single step. So you can use the same cells, do an exosome isolation that doesn't work at all, or you can have the same cells, you optimize the processes to isolate the exosome, you get a perfect result. So this is second layer of complexity. Third layer of complexity, what is their end? What do they look at as a proof of working or not working? What kind of marker do they look at? So what does it mean? It works. They check some blood markers. They did some movement like scoring. So what is their endpoint analysis, and how do they do that? So to summarize, there's a lot of complexity. That's why some say it works, some say it doesn't. Another layer is how many exosomes they injected. What was the time of injection? So all these pieces of puzzle, you put it together, makes it super complicated to compare to groups that they did the same therapy. I'm not sure if I answered that question. But remixing, I'll leave it up to Dr. Kaplan because I don't have any experience mixing MSC with exosome or mixing exosome with any other cells. So you want to comment on that?
No, I don't want to comment. I'm not an enthusiast for exosomes. I think exosomes are going to be much harder to get through the FDA and much more complicated in a batch-to-batch basis, as we just heard. I think that if we can change the way cells are delivered and site deliver them, we know we can get more efficacious results. There's a company down the road called VetStem in San Diego. They use stromal vascular fraction, and they've taken over 10,000 horses with tendinitis with a 79% cure rate. So the use of this preparation directly injected into the affected tendon becomes a very good product to use for these large animals that have tendinitis. So again, it turns out the same company is now in clinical trials with allogeneic, blows my mind, allogeneic MSC preparations for dog and for cat. And if Habib's curtain works, why wouldn't a mongrel marrow MSC work in a thoroughbred? And so the clinical trials on the early data, I heard rumors from the CEO are spectacular. So you can take that for whatever it's worth, but he's a good friend of mine. But again, if you just think about, if you go to the FDA and you have a product, the FDA, the first question they ask is, what are the animal studies? And if I say to the FDA, I got 10,000 horses that I've treated with a 79% cure rate, the guys in the FDA will say, we don't believe a word you say. Because who in their right mind would do a clinical trial with 10,000 horses? Well, it turns out the rules for veterinary medicine of animals and those for human are hugely different. So we have large animal studies that show that MSC and MSC preparations are very effective. We have to translate those into human studies so that we know what the non-responder rate is, what the efficacy rate is, how to direct deliver them, and how to more effectively analyze responders from non-responders. So we may be at the end of the beginning, but we got a long way to go.
This is more of a regulatory question. So there's a lot of IV enthusiasts here. I'm one of them. We're being cautioned from our consultants in the groups that I run in that you're going to advise us not to do intravenously, that's not a like-for-like service, that if you're doing it in a joint, you're going to be okay. If you're doing IVs, then you're, by theory, trying to affect the whole system. From a regulatory standpoint and our safety for the next year as providers, who could comment on that for me, please?
The guidance from the FDA is very clear that they have said and gone on record that IV delivery is more risky. Their whole approach is about risk. That's why there are bad actors who are doing things in California and Florida who their FDA is trying to shut down. They've called IV delivery more risky than other deliveries. That's their stance. So what you've been advised of is simply a sentence in a guidance that said it's more risky. I don't know that it's more risky, but I know that if you can go any other administrative route, do it.
Dr. Kaplan, you showed a slide that had muscle staining and some sort of fluorescent microscopy with CD receptors in a mouse, looked like a mouse muscle. You used a 2-day-old mouse. Are the number of stem cells higher in younger mice than in older mice? And what do you think that would affect an allogenic versus allo versus auto stem cells?
Yeah, so first of all, the MDX mouse is a very complicated mouse, and what happens in humans and in rodents is that the muscles have a defect in them. And so the muscles don't work so well, so they start degenerating. But the 2-week-old mouse is not showing degeneration. So what MSCs are doing there, I have no idea. So I would say what MSCs can do is protect against degeneration. And that's what they do in heart, that's what they do in other places. So with no data, I would speculate that if you got a positive outcome, that's the case. Muscular dystrophy, Duchenne's muscular dystrophy, very complicated disease. So for example, what's not well known in the medical and lay public is we have in our body molecules that appear during embryological formation of tissues. Those molecules change over and are replaced by other molecules in neonates. And then actually in adults, there's another change. So in muscle, there's 3 kinds of myosin: embryonic, neonatal, and adult. They come from different chromosomes in the body, etc. So you could have a perfectly normal embryology, you could have a perfectly normal early development, and when that changeover to the adult molecule occurs where you may have a mutation which doesn't work in that tissue, then the muscle degenerates. So in degenerative diseases, what happens is that your tissue-specific stem cell in muscle, called a satellite cell, goes to the area where you've had degeneration. That cell divides like crazy and makes a new myotube. So when Habib runs without working out and his muscles feel stiff and sore, he's killed myotubes. Those myotubes are getting rotor-rooted out by phagocytic cells, and the satellite cells are repopulating that area with a new myotube. You can do that in localized situations. If you have a massive degenerative event, can't work. So what happens in muscular dystrophy is and there's published papers that show this, is that the kids run out of satellite cells. They've used them up to try to regenerate the degenerative muscles. And so what's happened is then the muscle really degenerates. It's been degenerating all along, but the regeneration's been trying to keep up with that. So then the falling off the cliff occurs and the muscles don't work, and then they become paraplegics and blah, blah, blah. So can MSCs prolong the regenerative events? And so people are testing it in dogs. In the dog muscular dystrophy model, looks like that has MSCs have an effect. But it doesn't solve the problem. So the other people are working on gene therapies to try to get the dystrophin gene, which is missing, reasserted, and actually the CRISPR new DNA technology has a chance of fixing mutations. So there's some attempts to do that, and there's just a paper that appeared. There's another protein that's a cousin of dystrophins, which they upregulated in a dystrophin model in dogs and actually cured the dogs. So instead of dystrophin being inserted in the right place, this other molecule, dystrophin-like molecule, and it works fine. So muscular there's about 80 different muscular dystrophies, depends on where the mutation is and depends on the clinical symptoms. The degenerative aspect, MSCs can affect that, but it doesn't cure the person, it just makes the process longer. So again, I don't think there's a quick fix for that. I think the fix is going to be genetic, and all the gene jocks have to work on this problem, and there are people working on it.
Okay. Please. Wanted to thank you all for the high quality of information you gave us today. And I wanted to ask you also a question. Do you think that determining the immune profile of the patient may help to do the treatment in the right time and maybe to have incidence on the responder and non-responder people?
Your guess is as good as mine, but the immune response of the responder is only a piece of any therapeutic that you can imagine. So, and we can manipulate the immune response with drugs and with antibodies. So, for rheumatoid arthritis, there will be an antibody protocol which will affect the immune system and will affect some patients with rheumatoid arthritis. So there may be those situations where cell-based therapy probably shouldn't be used. It's easier to give a drug. But we don't like manipulating the immune system, except in life-threatening diseases like cancers, especially tumors of a certain kind. So there's not a big information base to know whether the response profile of a patient will determine whether the immune response profile of a patient will tell you whether you have a responder or non-responder. There are no assays involving the immune system for delineating responders from non-responders.
So the bottom line, yes, this is what Dr. Kaplan mentioned. There is no solid way to address that, but this is what we did at City of Hope, which mitigate the risk a little bit. So we were planning to. So the patient population was type 1 diabetes. So what we did, we first banked all our exosomes. So we had an exosome bank. Then let's say we wanted to enroll 9 patients. So we were planning to get the 5 ml of blood 1 month prior to the actual trial, get the PBMC, test our exosome bank, like 5-6 donors, to see which one respond best to that particular PBMC in terms of immunosuppression and Treg induction that we optimized. Then we're going to use that batch of exosome for that particular patient. Again, that doesn't mean that if you get a good response in vitro, are going to translate to in vivo, but at least helps a little bit to choose what we can do in our hands.
Yeah, so we're primarily be talking about bringing in the exogenous MSCs or the exosomes for treatment purposes, but I'm curious if you could talk a little bit more about what's happening to the resident MSCs and the resident exosome signaling that's starting to fail, and why bringing in exogenous material is actually helping in this case, because a lot of these cases I think are relatively minimal manipulation in regards of correction or things like that. So why bringing in the exogenous versions of what's already there is actually contributing to benefit the tissue?
So the question of endogenous MSCs, I could take a skin biopsy of everybody in this room. I can tell you how old you are, and I can tell you whether you have diabetes by the blood vessel density in the upper part of your dermis. So if you have diabetes, you have half the blood vessel density. So I can also define aging as a decrease in blood vessel density. So there are families that have a genetic risk for acute myocardial infarcts. So genetically, we can identify those families. And so I've asked cardiology residents to keep an eye on the kids of those people who are at genetic risk for acute myocardial infarct, to see if 5-year-old kids who come to mommy and say, oh, my chest hurts, is that angina, or is that just a kid has muscular problems in his thorax? So my bet is that a 5-year-old kid has a heart attack, and his blood vessel density is so high that he cures himself with his endogenous MSCs. So the way to prove or disprove that is get that kid in when he has chest pains and echo him and start doing every blood test you can on the kid and see if he's having an infarct, is whether he's having some kind of cardiac event.
Let's see, you get the insurance companies to pay for that.
The insurance companies will never pay for that, but the CEO of the hospital who has a kid who's had problems, cardiac problems, said that no problem will cover that. So I think this is an issue of, the question I always get is, why aren't my MSCs good enough if I have a heart attack, or if I have a stroke, or if I have a contusion of my spinal cord? The answer is not enough MSCs get there in a high enough dose, and it may be that autologous MSCs don't work in those acute environments. And so it may be that allo MSCs in the end are going to be the preferred treatment for lots of things. only because you can't mobilize MSCs. And actually, I want to make a hematological comment. GCSF is called a mobilizing agent when you give it to a patient. That's horse manure. Those molecules don't mobilize hemopoietic progenitors. They cause them to divide like crazy in marrow, and they get pushed. They're so crowded, they get pushed into the bloodstream. So at the moment, there are no molecules that have been known to mobilize MSCs. So that's the other problem, which is we don't know how to get MSCs from perivascular locations into the bloodstream to go to sites of injury. We know how to stick a needle in the bloodstream and get those MSCs there. So it's not that your MSCs are not plentiful enough, but I think you're too old at the moment to self-repair an acute myocardial infarct. But again, 5-year-olds break a leg, 3 weeks their legs healed. I break a leg, 3 months I'm still limping. So it's a question of access to therapeutic MSCs.
Go ahead.
Okay, I've bored you with the regulatory side of me. This is the science side of me. I got a PhD in biochem back in the days of Watson and Crick. But nevertheless, there's a whole dimension we're not talking about. Stanford's onto it, and a few other universities, and that dimension is age. It's been sort of alluded to. You can talk about old blood, new blood. 100 years ago, somebody put 2 rats together, an old rat and a young rat. And what happened? The old rat got smarter, tougher, bigger. The young rat got older, more degenerate. That we learned in Biology 1. Stanford is now running with that, and there's a company incubator from Stanford that are looking at young plasma. And there's a lot of animal proof to young plasma. They're taking these old mice, giving them young plasma, and they're finding the cheese as fast as the young ones. They learn it just as fast. It's an old concept, it's almost pre-science, but I figure if Stanford University has an incubator, what are they called, Alkahest, and they're actually doing clinical trials on different levels of plasma and possibly cells. And so you got old cells and new cells. And I know there's one thing, I'll give it right to you in a second. There's something called immune senescence. We all know about it. We just mentioned it, sort of. If you're dealing with senescent creatures like me, I would want my son's young plasma or cells. Why wouldn't
So that's a very important point, because there's a clinical trial at the University of Miami by Josh Hare on what's called geriatric frailty. So anybody over the age of 65, you can be scored on a scale for cognitive activity, for how fast you walk, for a variety of parameters, like 8 different parameters, for geriatric frailty. So 10% of the population above the age of 65 score as geriatric frail. Those patients are being given allogeneic, marrow-derived, culture-expanded MSCs, and in the phase 1 trial, their cognitive scores all improved. So there's now a phase 2 trial with 220 patients, and so you could say it's anti-aging, but again, if you have tissues and cells which are not optimally functioning, and you give MSCs and they go to those sites of injury and they help those sites regenerate or fix themselves, it will help A, your cognitive score, and B, your whole physiology. So there is a trial now going on, and there's also a company whose name I'm not going to mention, who has young cells, young blood cells, incubated with Habib's old cells across a filter. And Habib's immune cells are rejuvenated from having seen the molecules that come across this filter. So there are going to be procedures. Not wake-up calls, it's rejuvenation. It's taking programs and restarting them that have been shut down or been quieted. So again, this business of plasma is non-trivial, and also what bathes the cell will determine what the cell's reactivity is. And so that's another issue which is current. Again, I don't think it's going to help with my senescence, but it's coming out there.
Do you have a question?
Can I have two questions? Okay. First question is for Dr. Millar. It's about the exosome stability. And I attended a conference in Las Vegas, and one of the Korean company, they have lyophilized the exosome into powder form, and they claim that they reconstitute with saline, and then they still see they test some of the protein functions, and they retain 80% or more. So my question is, some clinicians also suggest that in treating brain-related conditions, and they use a nasal spray, and then each spray every 2 hours. So the exosome is sitting in the refrigerator for 2 to 3 days to finish the 5 cc nasal spray. So currently, I'm using the exosomes. We put in the minus 80 degrees, and we come out and we finish in like 10 minutes. So have you or anybody has tried to see if you set the exosome into the refrigerator for a couple of days and they're still active, and how do you test the function?
This is exactly what we did for our IND. That was one of the requirements for FDA. They asked us what is the stability. So what we did, we isolated a huge batch from different donors. Minimum you have to have 3 donors. We put one batch in the 4 degree, one batch is in minus 80. Then at the week 1, week 2, 3, 4, 5, 6, and 8, 10, till 6 months. So this is what we saw. If you keep it in minus 80 up to a year, you do see similar potency in our hands. Even that you cannot generalize, because this is how the mechanism it works, whatever mechanism it would be. This is relevant to our assay. In that particular assay, we do see efficacy in 1 year, similar to day 0.
In minus 80 or
in minus 80. But you can do another potency assay, whatever assay, in 6 months in minus 80, that you might not be able to see that. So that depends on the assay, all those conditions. But generally speaking, keeping it at minus 80 keeps it potent and stable till minimum 1 year.
What about minus 4 degrees?
4 degree, in our hands, it was potent till week 4. So after week 4, it started to degrade. But even that depends on the donor. Some donor degenerate very fast, like week 2. Some donors could survive till week 6. So that is also another issue. But to summarize, if you keep it in minus 80, you have better stability. If you keep it at 4 degree, they're gonna degrade much faster. Did I answer your question?
Yes, thank you very much.
Lyophilization. I've never done it myself, but for sure I know if you lyophilize the exosome, you definitely. What was that?
Lyophilize the cell. What will happen to the cell?
Yeah, so definitely it will damage RNA and protein to some extent. But depending on what kind of damage, because when you do the efficacy, do the potency assay, there's some host of protein and RNA which are the active ingredient, which I explained. During the lyophilization processes, if you affect those RNA proteins, you won't see anything. If you do not affect those, you might see. So lyophilization, I don't recommend for exosome. I was asked that question many times. I'm sure you're gonna see some degradation and less efficacious or less potency because of the RNA and the protein degradation, which is the key active ingredient in the exosome. But keeping it minus 80 can also increase the potency up to 5 years. So people have done that study in Japan. They look at the microRNA. They saw that you do see some degradation of microRNA after year 5. So looks like even keep it at minus 80 till for 5 years is going to be, very stable.
Thank you very much. My second question is for Dr. Kaplan. Because it's the first time for me to hear your lecture and also saying that MSC is not a stem cell. And so it's kind of a new concept to me. I don't know why it's not widely known. I think I probably need more lectures from here. But so right now I'm involved in a company who is doing the adipose derived stem cell extraction, and then we culture them in a special media and then convert them without genetic modification to a more embryonic state, in which they express some of those genes for embryonic state cells. And then we induce them back to the beta cell of the pancreas to make insulin. So the idea is to try to make a clinical trial using this cell to do treat diabetes. And currently we have already have pre meetings with FDA. So if this MSC is not a stem cell, so how do we say we're not doing stem cell, or I'm confused with the concept here.
MSC is not a stem cell. So when you take the cell and you de-repress it by incubating it with various drugs, you isolate a quote more primitive cell. It's several generations from what an MSC is in your body. So you're causing a cell to differentiate into a pre-islet cell or some cell that can make insulin. That has nothing whatsoever to do with the MSC. And it's far removed from MSCs that are used therapeutically. So you can get the cell from skin, you can get the cell from brain, you can get the cell from wherever you want, but by the time you've manipulated it to de-repress it and then engineered it to become a quote pre-islet cell, it has nothing to do with any cell that I'm dealing with. So you can call it whatever you want, and I won't take offense of that. That said, there are people who take embryonic stem cells or iPS cells and bring them up to what they call an MSC. Those are not MSCs they're hugely different than MSCs you get from adults from any tissue. So a cell which has brought along an embryonic lineage to an MSC-like cell, it has a completely different transcript profile than any of the MSCs that I deal with. So again, do I think that those cells can be used therapeutically? Not in the next 20 years, I'll tell you, but because they'll be very hard to be approved by the FDA because you've so de-repressed them that the FDA will want you to do every cancer study that has ever been done by modern man to prove that they don't form cancer. So it's a real problem. What real MSCs are being used for is to take authentic allogeneic islet cells from a deceased donor and giving those to diabetic patients and using the MSCs as chaperones instead of immunosuppression. So there are studies done at the University of Miami by Camillo Ricordi's group, which is trying to perfect that technique, which is to back off on how many islet cells you really have to give to a patient to get them to engraft. So again, that's number one. Number two is for diabetic patients, there are some experiments by Lola Reed at the University of North Carolina, where she's taking adult liver stem cells and using MSCs with those cells to get those cells to differentiate into islet cells. So a liver stem cell, if it's really a liver stem cell, it could give rise to pancreatic islet cells. So again, those studies are going on. And the third group of studies is to take cells which are found in the pancreas but are not islet cells, and seeing if you can get those cells to differentiate into islet cells and to use those for transplantation purposes. Most of the cases, they're trying to do it with allo cells because there's something about the host cells that cause them to be immunogenic, which is the problem in the first place. So there's a number of cell-based therapies for diabetes which are now being explored, mostly using MSCs as immunochaperones.
Thank you. Dr. Carrasco, Dr. Kaplan, Dr. Riazafat, Dr. Berger, we thank you so much for your contributions and for staying with us for so long. Do we have to put a few more coins in the meter? We are coming to the important part of the afternoon, which is the bars open. So cocktails will be served in 10 minutes upstairs in the Bay Room. We invite you all to join us for the next hour of cocktails, and then dinner is as advertised there. We have a very nice dinner banquet and a great evening, and you will have access, I promise you, to Dr. Kaplan singing some of his favorite tunes tonight. I thank you all for being here. Good afternoon. Have a great weekend.